Good afternoon, everyone. My name is Ákos Mátrai, and I would like to hold my 18 months progress report of my PhD work at the Center of Translational Medicine. I work as a specialist at the Department of Obstetrics and Gynecology at the Semmelweis University. My vision is to provide the optimal pregnancy care that contributes to the birth of healthy fetuses. My mission with my PhD work is to highlight the risk of infectious disease during pregnancy. First of all, a quick overview. We have two ongoing projects in which we examine the effects of maternal influenza in the first trimester, so during the pregnancy. Let's move on to the first project. The title is The First Trimester Influenza Infection Increases the Odds of Non-Chromosomal Birth Defects. It's a systematic review and a meta-analysis. A few words about the background. Flu is a very common illness. There are around 50 million illnesses worldwide in every year. And according to Central Statistical Office, we have around 400,000 cases in every year in Hungary. We know that the birth prevalence of congenital abnormalities can be estimated 3 to 5%, and these disorders underlie around 25% of perinatal mortality. Our aim with this study is to assess the effects of maternal influenza infection during pregnancy on birth defect. Our clinical question is, does influenza increase the number of congenital malformations during pregnancy? We are investigating the presence and the absence of influenza, and the outcome of the study are non-chromosomal birth defects. Our hypothesis is that influenza occurring in the first trimester increases the risk of congenital abnormalities. We made the systematic search in 3 big databases, and after we made the selection process, what you can see on this slide. Let's move on to the results. The first outcome are orofacial clefts. Orofacial clefts are really common birth defects. They have an estimated worldwide incidence 1.7 per 1,000 live born. Babies born with these type of anomalies have speech problem, conductive hearing loss, and feeding difficulties. We investigated 4 studies. The heterogeneity was quite low, and after the analysis, the overall results showed an increased almost 2.5 higher chance to have cleft lip and palate if the woman had flu in the first trimester. Let's move on to the second outcome, which are neural tube defects. Neural tube defects are the birth defect of the spine, spinal cord, or the brain. They happen in the first months of the pregnancy, often before the woman even knows that she is pregnant. After the analysis, we got that the first trimester maternal influenza infection was associated with an increased odds for developing neural tube defects. The heterogeneity was 0. The third outcome are the congenital heart defects. These are the leading cause of perinatal mortality or infant death. We investigated 3 studies in this case. The heterogeneity was also 0, and after the analysis we got that first trimester maternal influenza infection was associated with an increased odds. What does it mean? It means that if the woman had flu in the first trimester, she has 60% higher chance to have congenital heart defects. Let's move on to the strengths and the limitations. Among the strengths, we have to mention the rigorous methodology. This is the first meta-analysis providing a comprehensive overview about maternal influenza infection in this critical period in the first trimester and its association with all non-chromosomal birth defects. Among the limitations, we have to mention that the influenza definition was based on the symptoms, and the most cases were self-reported influenza infections. After the analysis, we can conclude that the influenza in the first trimester increases the risk of non-chromosomal birth defect. Implication for practices. If flu is presented in this critical period, great emphasis should be placed on prenatal screening, and we should make efforts to prevent flu during the pregnancy, and we should vaccinate against influenza. Implication for research is to develop and maintain a detailed, comprehensive database about congenital abnormalities, and maybe it would be better if we do in the future prospective observational studies when the influenza infection is confirmed with PCR. We have submitted this project in last October. We had a major revision. They accepted our article, and it has been published in the Journal of MDPI Viruses in last December. Let's move on to the second project, which is the investigation of the effects of maternal influenza during pregnancy on birth defect in the Hungarian population between 1980 and 2009. It's a cohort analysis. As I mentioned before, flu is very common illness. It happens during epidemic outbreaks between December and March, and the non-chromosomal birth defects are the leading cause of perinatal mortality. Our aim with this study is to assess the effects of maternal influenza during pregnancy on birth defect in the Hungarian population between this time. Our clinical question, our PO, and our hypothesis is the same, what I mentioned before at the meta-analysis. A few words about the database. This database is the Hungarian Case Control Surveillance of Congenital Abnormalities. It is unique in the world. It contains around 90,000 data, around 90,000 pregnancies, and it was established in 1980. Let's move on to the results of this cohort analysis. First, we verified that influenza is a risk factor for congenital abnormalities. Then we verified what kind of disease can develop if flu is presented in the first trimester. These are the most frequent disease, and we divided them in three big groups. This group is congenital heart disease, neural tube defects, and cleft lip and palate. After the analysis, we got that the odds of having neural tube defects is 2.2 times higher in the influenza-infected group than in the control group. We got the same conclusion with the oral clefts. The odds ratio is 2.2 in this case. And after the analysis, we got that the first trimester maternal influenza infection has an association with increased odds for developing congenital heart defects. We have submitted this manuscript in May into the Divan journal, but its status is now sent to reviewers, so we have to wait now for the decision. A quick overview to project, and at the end of the presentation I have to mention that we had a success with our first publication. After the publication, around 70 Hungarian and around 15 international media company reported on this article, such Hungarian Index, Telex, Origo, Club Radio, retroradio, and the international is Telegraph, The Sun, and the NetBounce, which is very popular in the UK. At the end, I would like to close my presentation with a quote from Steve Jobs. Sometimes when you innovate, you make mistakes. It's the best to admit them quickly and get on with improving your other innovation. Thank you for the attention.
Couple of things. I'm not going to go into detail with a paper that is so highly cited by The Sun, but I had a few issues there. One of the issues is when you're presenting these figures, you mentioned that the heterogeneity is low. We don't really. If you go back, I'll just show you that. Yeah, it's the truth is you have no idea what the heterogeneity is, because if you look at the confidence interval estimate of the heterogeneity, it's between 0 and 85%. Right, so with 3, 4, 5 papers, there's no real need to look at heterogeneity unless there is something really bad going on, and I would not even highlight it. You know, you're trying to estimate the standard deviation of something based on 3 data points or 2 data points. I mean, Russian mathematicians can do it, but let's leave it to them. That was one thing. The other thing I think would really benefit your presentation if you'd have the prevalence values of defects on, because then it would be very easy to judge the true effect. That's one thing. And these were, and you also mentioned, yeah, another thing, you also mentioned that these are worldwide studies, so they come from all around the world.
Yes.
It's a bit controversial when you have only 3 papers or 4 or 5 papers that you say it's a worldwide. You know, usually this would imply that there are 10 or 20 or 30, 50 papers, and they are so yeah, that was a little controversial in my opinion. And so one more question about this topic is these are I presume, like, let's say Cese et al. 2007 published some kind of a multivariate analysis, right? So these odds ratios are coming from a model.
Yeah, from a registry.
From a registry, and then they modeled it.
Yes.
They had some kind of an analysis, and you're pulling the results of the analysis.
Yes.
Did you look at what variables they were using to adjust?
Yes.
For
maternal age, smoking habits, use drugs during the pregnancy. Yeah, almost the most studies have adjusted for these kind of things. Okay,
so they're at least domain-wise they're adjusting for the same studies, for the same variables. Okay, that's, I think, much more important than heterogeneity. Okay, so I would highlight that these were adjusted for. Okay, and the last thing is, I didn't really understand in your second project, in the table it said matched controls. So this is a propensity match study?
Yeah, if this is a huge registry.
Yeah.
And every case has 2 healthy. If one baby has a birth defect, they include into the registry 2 other babies in this time, in this area, in the same area, healthy fetuses.
Ah, okay. So it's an inherent matching,
yes.
not
yes.
retrospective.
No, it's an inherent matching.
Okay. Okay. Thank you very much.
Thank you so much.
COVID-19 was an exclusion criteria?
Yes, of course.
It was an exclusion criteria?
Yes. Only influenza.
Only influenza. And why was COVID-19 an exclusion criteria? When did you close your search?
There was 2 search because they asked in the major revision to rerun the
Yeah, no, that's okay, yeah. But because you decided on this topic in September 2021. That was in the... Yeah, so I just wonder, because that would have been a massive catch, you know. 250 articles per day were published about COVID-19 on PubMed. So that would have given you quite a large amount of study. You're not planning to do a similar one for COVID-19? And
we haven't got any experience with COVID like influenza. The fever is the teratogenic agent in these things. If she had COVID-19 in the first trimester with fever, it's dangerous for the development of congenital malformations.
And how was influenza diagnosed in these years and in these papers? Based on clinical symptoms? Or?
Based on clinical symptoms. Yeah, that's a limitation of the study, because PCR is really expensive. So before COVID, we didn't do PCR test for any. Yeah, but nowadays also.
Yeah, the first hit was the H1N1 when we became alert that there is a problem here.
Yeah. In this year, when we made the COVID tests, we had a lot of influenza in the test, because just as a secondary statement came the piece in the PCR, the influenza 2, and there were a lot of influenza without any symptoms.
If we see our cohort analysis and basically Cäsar study, then we included patients with influenza during epidemic outbreaks. So we know from the cohort when it happened, and GP or obstetrician has used the ICD code of influenza, and it's in the registry. But in the other studies, they mentioned it's an influenza, and
it's a problem. It's a problem in my eyes, because, then you can say these symptoms. If the patient had these symptoms, then it can lead to problems, but not influenza.
There was a meta-analysis in this topic before ours. So they included a lot of study in which they mentioned flu-like illness with fever, without fever. We excluded them in this study. So yeah, we know that it's a problem, but all over the world we don't use a PCR test for this diagnosis.
Do you have any statistical data about Hungarian pregnant population, about the vaccination rate during the pandemic?
During the pandemic,
during the influenza pandemic, not
or with influenza.
Influenza.
The worldwide incidence is around 35%, and the Hungarian is less like this.
In the Hungarian registry, what is the time of questioning? So when we collect the data?
There was 3 ways to collect the data. During the pregnancy, because the maternal logbook, there was in every cases. So from the maternal logbook, we know what kind of disease they had during the pregnancy.
It's from the medical record, but it's in the hospital system. So and it's not direct questioning the mom.
Yeah. Okay. But the midwives, after the delivery, the midwives went to the patients and they do a questionnaire. And also from the medical data from the hospital too.
So my issue is the same as the previous ones, and I am a bit confused that you have highlighted that one of the biggest issue with the meta is that the diagnosis of influenza, and then you repeat in this systemic issue in your cohort analysis, and I can't see the effort that you have to try to do a kind of a statistical analytical way to deal with this kind of biases and confounding factors what you have in the data collection. I'm not familiar with this kind of methods, but I'm sure that maybe Peter has some idea how can we deal with them. And yes, and the other thing is that I'm not an infectologist, but the influenza virus itself changed a lot during the time. And you also have to consider this as well when you are trying to figure out the association with a kind of influenza, flu-like symptoms, and associations with congenital diseases. And one just minor thing that maybe it's not necessary to use developing congenital heart disease, developing neutral tube defect. It's just enough if you say that congenital heart disease, so influenza-like symptoms, seems to be associated with this and that.
I'll be your advocate here, okay? What are the possible outcomes? A, it's the flu causing it, right? B, there are a lot of people with flu-like symptoms. There's one specific rare thing that's causing it, which is not the flu, but you have to still find it, right?
The fever is the cause. We know it.
Oh, you know it?
Yeah, the fever is
okay. Okay, then it's very simple, because it doesn't matter what causes the fever, right? Or does it?
No, yeah. But influenza is a really common disease, and influenza, if somebody has influenza, has also fever. In our cohort, they used the ICD codes.
We use the BNO codes and the ICD codes as per financial issues. So I can put in the season of the influenza, I can put influenza as a code to anyone who just mentioned that, oh, maybe, yes, I had a small headache and a bit chilly, yes, and get more money from the government.
Case, we should do PCR tests for everyone.
Yeah, for this specific question, I think you should organize a really good clinical trial with PCR, and the PCR is not so expensive.